So we'll start with today's topic of bacterial vaginosis. So bacterial vaginosis is the commonest cause of abnormal vaginal discharge in women of childbearing age. Prevalence is around 5% in a group of asymptomatic college going students to as high as 50% of women in rural Uganda. A prevalence of 12% was found in a pregnant women in the United Kingdom and of 30% women undergoing termination of pregnancy. So here these all prevalences will not be asked, but you may have a simple question: the commonest cause of abnormal vaginal discharge in women of childbearing age group. So bacterial vaginosis is the commonest cause of abnormal discharge. Okay. And in pregnancy, the 30% prevalence, in women undergoing termination of pregnancy, 30% is the prevalence, while in pregnant women, it is at 12%. We know well that lactobacilli are dominant bacteria in the healthy vagina. The pH is maintained below 4.5 and there are low levels of other bacteria. What happens in bacterial vaginosis? The pH of vaginal fluid is elevated above 4.5 and it may reach up to 6. Lactobacilli may be present, but the flora is dominated by the other anaerobic and facultative anaerobic bacteria. Conventional culture techniques identified Gardnerella vaginalis, Prevotella species, then Mycoplasma hominis and Mobiliancus are those most commonly found. Okay, here you remember the presence of Gardnerella vaginalis only is not an indication for treatment unless the patient is symptomatic, because Gardnerella vaginalis can be a commensal also, it can be present, but if the patient is symptomatic, then definitely we need a treatment. Coming to the clinical features, so symptoms will be offensive fishy smelling vaginal discharge, not associated with the soreness, itching or irritation, and in many women approximately 50% are asymptomatic. Remember, this can be a question: how many cases are asymptomatic in cases of bacterial vaginosis? So 50% cases will be asymptomatic. Then signs: thin, white, homogeneous discharge coating the walls of the vagina and vestibule. Bacterial vaginosis is usually not associated with signs of inflammation. Okay. So, what are the associations of bacterial vaginosis? Bacterial vaginosis is not sexually transmitted, but there are associations of bacterial vaginosis with other STIs and other genital infections. It has been linked with increased risk of HIV acquisition. The prevalence of bacterial vaginosis is high in women with PID. Bacterial vaginosis is common in some population of women undergoing elective termination of pregnancy and is associated with post termination of pregnancy, endometritis, and PID. In pregnancy, bacterial vaginosis is associated with late miscarriage, preterm birth, PPROM, and postpartum endometritis. So these are the complications in pregnancy due to bacterial vaginosis. That is late miscarriage, preterm birth, PPROM, and postpartum endometritis. Okay, bacterial vaginosis has been associated with increased incidence of vaginal curve cellulitis and abscess formation. So we should know the gynecological complication also and the obstetric complication or the high risk associated with this. Gynecological vaginal curve cellulitis and abscess formation following vaginal hysterectomy. But it's unclear whether this problem is in the UK practice, where many units administer perioperative antibiotics. Now, coming to the diagnosis. So, I have already mentioned isolation of Gardnerella vaginalis cannot be used to diagnose bacterial vaginosis, because it can be cultured from the vagina of more than 50% of normal women. There are two approaches. One is to go ahead with the Amsel's criteria, and other to go ahead with the Gram stain of vaginal smear, on which you will have two criteria: either Harrison's criteria or the Nugent criteria. Okay, so you have one Amsel's criteria. In Amsel's criteria, there should be three criteria out of four criteria should be present. You can take the picture of this. No doubt this PPT will be uploaded to our website. You will have an access to this. But if you want to remember handy, you can have a snap of this. So Amsel's criteria, at least three out of four criteria should be present, and these are: one, thin homogeneous discharge, clue cells on microscopy of wet mount, then pH is more than 4.5, and release of fishy odor on adding alkali 10% KOH. Okay, so out of four, at least three criteria, these are the Amsel's criteria. Then another approach is stain. You take a Gram-Stein vaginal smear and evaluate it for either Hayeson's criteria or Nugent criteria. They are almost similar. We'll see what are the Hayeson's criteria. It says the smear is graded as grade 1, grade 2 or grade 3. Grade 1 is normal, where you will get mainly lactobacilli. Okay, lactobacillus morphotypes are predominant. Then grade 2 is intermediate, that is a mixed flora. You will have some lactobacilli, but Gardnerella or Mobilingus morphotypes are also present. Okay, so that is intermediate. And grade 3 is a bacterial vaginosis, where predominantly you will get Gardnerella and or Mobilingus morphotypes, and there may be few or absent lactobacilli. The Nugent score is derived from estimating the relative proportions of bacterial morphotypes to give a score between 0 to 10. So the same vaginal smear, it is scored between 0 to 10 depending upon the proportion of various bacterial morphotypes, depending upon the proportion of lactobacilli and other anaerobic bacteria. If the score is less than 4, then it is normal. 4 to 6 is intermediate, and score of 6 is bacterial vaginosis. This you can remember. Sometimes they may give you the score and will ask you the interpretation. So score of 6 or more is bacterial vaginosis. Okay. Coming to the management. So general advice, what we have to give to the patient? Patient should be advised to avoid vaginal douching, use of shower gel and use of antiseptic agents or shampoo in the bath. Then treatment is indicated for one, symptomatic women, women undergoing some surgical procedure, and women who do not volunteer symptoms may elect to take treatment if they are offered. Okay, so sometimes the patient may not have the symptoms, but they may accept the treatment if the treatment is offered. Okay, they may report a beneficial change in their discharge following the treatment. So if the treatment is given, there will be beneficial effect in the vaginal discharge. So what is the recommended treatment? It is metronidazole 400 milligram BD for 5 to 7 days. Okay, so just remember, metronidazole 400 BD for 5 to 7 days, or metronidazole 2 gram single dose. Here it is better to give the treatment for 5 to 7 days, okay, rather than single dose treatment. Okay, so the treatment is same, actually similar treatment for trichomonas vaginalis, but here in bacterial vaginosis the treatment is for 5 to 7 days, metronidazole 400 milligram BD. Okay, then alternative is a metronidazole 2 gram single dose. While in trichomonas vaginalis the first will be 2 gram single dose is the first choice. Okay, and locally what we can give is intravaginal metronidazole gel, that is 0.75% once daily for 5 days. Intravaginal clindamycin cream 2% once daily for 7 days. You have to remember for how many days also, because they will give the option metronidazole 400 BD for 5 days, metronidazole 400 BD for 7 days, metronidazole 400 BD for 5 to 7 days, metronidazole 500 BD for 5 days. So these kind of confusing options will be there. Whatever is given in the guideline, you have to select that specific option. Okay, so sometimes what happens, a particular drug is available in our country in different strength, but whatever is given in the RCOG guideline, you have to remember that particular strength, that particular dose and that particular duration. Okay, so metronidazole 400 milligram BD for 5 to 7 days, or metronidazole 2 gram single dose, and intravaginal metronidazole 0.75%. Remember the percentages. Okay, so same, they can be give different percentages. Okay, intravaginal clindamycin 2%, that is given for 7 days. Alternative regimen is a tinidazole 2 gram single dose, or clindamycin 300 milligram BD for 7 days. A test of cure is not required if symptoms resolve. So test of cure is not required for this bacterial vaginosis. Now caution. With metronidazole treatment, alcohol should be avoided because of the possibility of disulfiram-like reaction. There are no data on the risk from consuming the alcohol with intravaginal metronidazole gel, but it is still not recommended at present. So whether it is an oral treatment or vaginal treatment, avoid the alcohol. Okay, clindamycin cream can weaken the condoms, which should not be used during such treatment. Then pseudomembranous colitis has been reported with both oral clindamycin and clindamycin cream. So these are the side effects associated with clindamycin cream. So sometimes they can ask this as a SBA, adverse effects of clindamycin. So one, it can weaken the condoms, and second is a pseudomembranous colitis. So sometimes the you need to ask the history of contraceptive, what contraceptive they are using. If the patient is on barrier contraceptive, then you might need to advise her that she will require to use additional contraceptive. Okay. Allergy to the metronidazole is not very common. If the allergy is there, then 2% clindamycin cream can be used for the women who are allergic to the metronidazole. Pregnancy and breastfeeding, meta-analysis have concluded that there is no evidence of teratogenicity from the use of metronidazole in women during the first trimester of pregnancy. Okay, so metronidazole can be safely used in all three trimesters during the pregnancy. Okay, so thank you.